thank you for coming. And the ABCs of MAT, I didn't know if you all would understand what MAT stands for, but it's sort of a buzzword that's been going around. You'll hear more of it. I'll be talking about it specifically. But medication-assisted treatment it describes medication that we can use now in addictive disorders. Now we have them, it's not just for opioids. You can think about folks who are smokers. We have nicotine replacement. We have other medications that can be used in those addictive addiction. And then also we have those for alcohol as well. These are way underutilized. It's about, of a population of patients who would qualify for these, only about 10% of people are actually avail of this. So they're markedly underutilized and also misunderstood in many arenas. So I wanted to at least give you some insight into using medications for an opioid use disorder, and then hopefully leave enough time for questions. This is such a big, huge topic that I tend to stuff a lot in, so bear with me for the variety that I'll be talking about. But essentially it's talking about treating addiction. Objectives and those elements that I want to talk about today. We'll be talking about the elements that are involved in the opioid crisis, just a brief overview of maybe why we are where we are today. A review of the definition of the disease of addiction. To understand the basic physiology of opioid drugs in the body. And then to review the evidence-based treatment. Review evidence-based treatments for opioid addiction, or MAT. I'm going to start with, this is a short video. Actually, it's not really that short. It's about 6 minutes. But on November 17th, our Surgeon General, U.S. Surgeon General, came out with a report about addiction and alcohol and drug addiction in health. And this is a portion, it's a 3-hour program, and there's a pretty pertinent component that I wanted to share with you today.
You're here today, a very special history-making day. The release of the Surgeon General's report on addiction is very likely to be a watershed that will finally help us turn the tide against addiction in this country. And Facing Addiction is very proud to be co-sponsoring this event. It will become clear I'm not a doctor, I'm not a researcher, I'm not an addiction expert. I am just a guy whose life and whose family was turned upside down and was ravaged by addiction, as is the case for millions of families in this country every single day. And as we know, it's all families of every color, every economic background, every education, every geography, every moral code. It doesn't matter. Addiction is an equal opportunity offender. My oldest boy, Austin, started drinking when he was 14. By 15, he was using marijuana. By 16, it was prescription pills, and it got worse quickly from there. Through 6 years, we saw countless therapists and went to interventions and therapeutic boarding schools and emergency rooms, and through it all, my family and I were simply terrified. We were uncertain where to turn next because, in large part, there's no roadmap, which is why some people call this a do-it-yourself disease. And so you're surrounded with helplessness and hopelessness, really never knowing where to turn next. And of course, then there were the staggering expenses. And through it all, of course, there was that stigma that leads to shame. My son was clearly ashamed that he suffered from addiction and that he couldn't overcome the damn thing. You know, and it's imponderable when you think of it to imagine somebody being ashamed because they have an illness in this country. After 6 years, Austin was doing quite a bit better, and we were overjoyed. As you can imagine, there was optimism and hope. He was going to go finish college and go on to grad school, and his music had never been better. So, you know, things finally, thank God, were turning up. And then I got that phone call that brings any father or mother to his or her knees, that my beautiful boy was dead of a drug overdose, found slumped over his kitchen table. And in his apartment, which I can't imagine is a very attractive way to leave this earth. And a part of me, as you can imagine, died that day as well. And I think about this a lot, but our relationship was exceptionally close. Austin and I usually talked and texted, not one or the other, every single day. But I am certain that as he was struggling, he was too ashamed to pick up the phone and say, Dad, God damn it, I'm struggling again, and I need your help. And so he didn't. And now mine is just a sad story, and my son is a memory. So, but it is only one story, and it's the last we talk about me because this happens nearly 150,000 times a year in this country. Someone, usually a young adult, dies from alcohol or other drugs. And that number, in turn, pales in comparison to the more than 20 million who are suffering from addiction every day, and only 1 in 10 receives any treatment ever. Can you imagine, for any other illness, can you imagine only 1 in 10 people ever receiving treatment in this country? I doubt that you can, because it is unimaginable. It's also unconscionable. Today, thanks to the work of the Surgeon General, we're going to hear many messages of hope and help to replace the hopelessness and helplessness, and there will be optimism. This afternoon, people on this stage will give us a roadmap for how we'll finally address the addiction crisis in our country. It is clear to me that America is saying it's time. Last week was an unusual week in this country, and there was a fascinating survey that came out after the election that said supporters of both candidates agreed on only one thing. That unto itself may not be surprising, but this is. They gave addiction the highest combined score and the smallest partisan gap of the 13 issues deemed to be the most pressing issues facing our country. On that list was terrorism, illegal immigration, climate change, job opportunities, and gun violence. Not a pretty list. Think about that. We all want this nightmare to end tomorrow. But sadly, we won't solve this crisis overnight. This is going to be a long fight. And today is just the beginning of a long journey. People need to be re-educated. Structural problems need to be readdressed. And we have to erase the stigma that keeps this issue in the shadows and prevents real change and real progress. Mostly, we need to build a movement. And we need to build a movement among people who really want to fight this fight. It is one thing to care deeply about the addiction crisis, but we need those people who care to come forth and join the fight and to lend their voice and to support in any way they can. To accomplish the tremendous amount of work that needs to be done to battle addiction, we need tens of millions of people to lend their help, just as they do every day with other major health issues such as cancer, heart disease, diabetes, and the list goes on. We absolutely can defeat addiction, but we all need to do our part. With 1 in every 3 households impacted by addiction, it is clear everybody knows somebody whose life has been turned upside down or worse. I so deeply hope today that today marks the day when all of us can begin facing addiction in America. Thank you.
This is from the Wall Street Journal showing the number of deaths from opioids, all opioids. And you see 9 deaths per 100,000 people average nationally. And then the pertinent point to pointing that out is that we in New Hampshire, we know that certainly we're high up there, and to compare, we rank number 3 in our nation from 2014. 15's data is not in as far as I know, because we had a 26.6 death rate out of 100,000 from opioids. So all opioids, I'll be talking about differences between opioids, but there's your natural and semi-synthetic, those would be prescriptions. Heroin in blue, you can see the pretty sharp climb there. And then you see the orange, the fentanyl. And I'll say from my own personal experience, at this point, if I have a patient who comes in and says, I had a lapse over the weekend, or my disease flared and I used again, and I check a urine, I'm not seeing heroin anymore, it's all fentanyl. And it's really scary. So I do tell my patient that, did you know it was fentanyl? And oftentimes they don't. So we also made the Wall Street Journal in August, New Hampshire did, because we now not only have a projected death of 482, it's actually 488, I heard yesterday. But clearly this is something that's going up, and something that we're going to see it get worse before we see it get better. I think that's sort of my judgment. I'm so sorry you can't see the the various rainbow of causes. I'll just point out a couple. Maybe I just can't see them because it's so small here. Back in the 90s, I graduated from medical school in 1996. And it was right around that time, I feel like it was like the last day of medical school, that I remember an oncologist running in. This is this vision I have, and saying, we have a great medication to use now, and it doesn't cause any addiction. And it's a great medicine, it's MS content. So prescribe it. You can prescribe it for people with cancer, you can prescribe it for people with pain management, and there's practically zero addiction associated. That's my vision of that. So certainly that was sort of flung to the medical wards, medical societies, in large part from drug company really spreading that false information, as we know now. The Joint Commission is an accrediting body that comes in and determines how well are the hospitals doing. It really is going to kind of give them a rank so that people actually say, yeah, I want to come to Concord Hospital. Pain management became a really, really big component of that rank. In general, physicians' lack of education around this. So I'm not an MPH, I'm not a researcher. I often will say, how can I distill this information? And I go to experts and say, what should we use? You should use MS content. And so we tend to say, well, is this proven? Yep, it's fine. But really, I hadn't had a whole bunch of experience or training in pain management. And our desire to help patients. It's really hard when somebody comes in and says, I'm getting worse. This isn't working, I need a higher dose. Oftentimes you'd say, okay, press Gainey. That's anything. If you go to see your doctor, whether it's in the office or in the hospital, you're going to receive a query to find out how well did they do. And certainly one of the questions has always been, how is your pain managed? Those press Gainey reports then reflect back on the physicians and could determine whether they get a raise, bonus, etc. Potency of medications, not understanding the differences between opioids and how potent is one compared to the other. And then really no screening for addiction. This is all information that's come through in the past 10 to 20 years. We really haven't been very good at screening folks for what's your risk, what are the chances you might have a higher risk for or vulnerability for addiction. Insurance companies. So I have a story. One of my best friends is an internist, and she takes care of a lot of folks who are frail elders. And she was relaying this story to me that she had a patient who had knee pain, and she said, a lidocaine patch would be great. That's just a sort of a numbing patch, just put on that local area. The insurance company wouldn't cover it. They recommended she use oxycodone for somebody in their 70s or 80s. And we see this, it's one of many examples. And then drug cartels. And I'm listening to a book right now in my car called Dreamland, and it's really this expose of really what was happening all at the same time. I guess it was time for me to move on. So this is something that was actually printed in the Joint Commission on National Pharmaceuticals, stating specifically, in general, patients in pain do not become addicted to opioids. Although the actual risk of addiction is unknown, it's thought to be quite low. What does that mean? What does quite low mean? Is it 1%? We still don't know what that is. Even with all these studies we're doing, I've heard it quoted 2%, and I've heard it quoted 50%. And sometimes it depends on what the person's being treated, what type of pain they're being treated for. Folks with back pain seem to have a higher risk. But, there's a lot of different variables, so we really don't know. So I wanted to just review opiates versus opioids. Maybe you've heard this in the press. Opiates are naturally occurring pain relievers. They're made from the opium plant, and they include morphine, codeine, and then one called thebaine. Opioids are synthetic, so we take the molecules from that naturally occurring plant and we kind of mix them up and we put them into medications: oxycodone, hydrocodone, fentanyl, methadone, and heroin. And I've never seen heroin live. I shouldn't. I'm not a law enforcement person, but those are examples of what a bag of heroin is about 0.1 gram, is my understanding. Now, the physiology lesson, just so that there's an understanding of, well, why do people, what happens when somebody takes an opioid? And opioid receptors, so I think of these as a key, a lock and a key. So the opioid is the key, and these receptors are the locks. So if somebody were to take oxycodone, they kind of lock into places in these areas. If you've ever taken oxycodone or a pain reliever after surgery or maybe cough medicine that has codeine in it, you might notice, gee, I can't go to the bathroom. It locks things up. It stops the gut. This is where pain relief happens. So it stops the pain receptors from being able to reach the brain. This is where the respiratory system comes into play, because that's our central respiratory system. So if opioids or an opiate is locked in there, at some point, it's slowing down respiration to a point of stopping respiration. And if we don't breathe, we don't live. This is actually the area of reward. Actually, they kind of go hand in hand, the cortex and the midbrain. This is where addiction happens. In some people, certain vulnerable people, exposures, different types of opioids. There's a variety of risk factors that come into play, but that's where reward is experienced. So excuse me for reading, but I think it's pretty pertinent. The addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. And in the picture that I just showed, where that reward happens, it's also where we have our motivation. It's where we house emotion, our memories, and this is why this circuitry comes into play. So dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. And this is the only disease that spiritual is actually included in the definition. This is straight from the American Society of Addiction Medicine. And when we talk about spiritual, I talk about connection, because if there's one thing that we know happens to folks who have addiction, is they start becoming disconnected from their families and disconnected from themselves. It disrupts control, so a lack of control and use, creating cravings, a dysfunctional emotional response, problems of behavior. And I'd like to say, expound on that, because we experience almost every day in the hospital patients who may be being treated and have substance use disorders, and there'll be a behavioral concern. And it can be devastating. We had a case yesterday where the patient ended up leaving. And that behavior is all part of this disease too, because it's not recognized by the patient that this is, my behavior is not what I think it is. It's how we're perceiving this behavior as bad behavior. They're behaving this way because of this disease. And then it's also marked by relapse and remission. And there's a saying in addiction, relapse is the rule, it's not the exception. Folks who can stay sober or abstinent for many, 'many years, it's definitely not the rule. That is possible. And unfortunately, we see progression, disability, and obviously premature death. At the National Institutes of Drug Abuse, they've done many functional MRIs to show the changes in the brain that happen with addiction. Dopamine release is thought to be sort of that feel-good. That seems to be that sort of the no pun intended, the buzz neurotransmitter that's released. It's actually what's released after we eat. It makes us feel good when we laugh. And it seems that folks who have addiction have reduced dopamine. And so what happens is there's this manifestation of motivation to use, again, to feel better. And not even recognizing that that's something that is happening nearly unconsciously. So needing to use more substance or even doing certain behaviors that are considered addictive. And at some point, and the vast majority of my patients who come to see me, they're not trying to get high. They're trying to feel okay, and it's not working anymore. So at some point, I've heard people say, I couldn't stay sober and I couldn't get drunk. You know, it's just, I'm in no man's land and I need help. So I call this time for catch-up because historically we've always kind of pushed addictive disorders to behavioral health, and even among behavioral health, to the addiction-specific clinics, or really kind of being out of the realm of mainstream medicine. And so it's time that we do catch up and realize that this is a brain disease and the brain is part of the body, and it is treatable and something that we need to learn more about. So we know that substance use disorders double the risk of several serious chronic diseases. It's responsible for many more deaths probably than we attribute single substances to. Just yesterday, the 2015 opioid overdose deaths statistics came out, and you saw that on the news. Over 31,000 people last year died of opioid overdoses. But if you look at the number of people who died specifically from alcohol use disorders, it's in the 80 to 90,000 range. And then you add in tobacco, and you know that explodes. So this is really significant, the number of people we lose each year to substance use disorders. And then if we're not being aware of patients who are using substances, whether it's alcohol or various either illicit substances or prescriptions, and we're prescribing more medications, then we may be facing interactions potentially if we're not evaluating our patients in a holistic way. And I apologize for this. Tina's going to be like, too many words on the slide. But this was a specific statement from Dr. Murthy, our U.S. Surgeon General, and the gentleman at the beginning in the video stated it quite well. But we also need a cultural shift in how we think about addiction. For far too long, too many in our country have viewed addiction as a moral failing. This unfortunate stigma has created an added burden of shame that has made people with substance use disorders less likely to come forward and seek help. It has also made it more challenging to marshal the necessary investments in prevention and treatment. We must help everyone see that addiction is not a character flaw, it's a chronic illness that we must approach with the same skill and compassion with which we approach heart disease, diabetes, and cancer. I remind myself that every day. And my nurse care coordinator and I often, when we don't know what to do with a patient, we go, okay, well, what would we do if they had diabetes? What would we do if they had hypertension? What else can we offer them? Rather than saying, oh, you did it again. You know, it's really saying, what can we do to help you? We realize that what we're doing isn't enough. And the language that we use, we know influences how people are treated, and we know influences outcomes. There's many studies now that show if we're using certain words, we are going to decrease people's chances of getting better. And so therefore, on the left-hand side are things that we still see in the newspaper, we'll hear in media, as opposed to really our preferred language. So calling somebody a person with a use disorder or with addiction, the disease it is. Even saying, track marks, that conjures up, evidence of intravenous drug use, IVU. Clean or dirty, we often hear, their urine was dirty. I mean, if somebody had sugar in their urine, we don't say that, the person who has diabetes, their urine is dirty. Urine demonstrates adherence to or for a certain medication I'm prescribing, or it's positive for cannabis. And then IV drug abuser, instead saying person who injects drugs. The treatment of addiction is manyfold, and I call it, and when I introduce the concept to my patients, I call it a recovery platform, because we're going to put things on this platform to really give people the best opportunity to maintain abstinence and to live a really healthy life with wellness and joy. So abstinence-based treatment with psychotherapeutic interventions, it's kind of what we kind of went to in the past. We still want to use several of those psychotherapy, etc., because we know that that's evidence-based and is helpful. Mutual help also has significant evidence behind it for connecting people and for giving people a community opportunity, because they don't want to have to come see me for the rest of their lives. Well, one guy does, but because he doesn't want to go to these meetings, I'll just come and see you. But what we know is really it's incredible the support that can be gained by others with lived experience. In recovery communities, we've seen certainly an uprising of grassroots efforts. Hope for New Hampshire Recovery just opened their 7th but 6th, because one of them's closing, in Franklin just yesterday. So they've opened 6 in 1 year recovery communities. And then we call it medication-assisted treatment. And American Society of Addiction Medicine is really starting to kind of take this and say, you know what, let's just call it medication. Because we don't call people who take medication for their blood pressure medication-assisted treatment for their hypertension. We say it's medication for their hypertension. It's a treatment. OAT stands for, we use all these abbreviations, opioid agonist treatment. So getting into medication, I have to let y'all know you're getting more of an education than many, many doctors right now, because a lot of docs haven't heard, these kinds of things. They know it's there, and but it's relatively new. These are some of the effects that we know that using medication for use disorders reduces. So it's certainly with folks who inject drugs, people who inject drugs have an increased risk for HIV, hepatitis C, and actually sexually transmitted diseases we also see pretty significantly. We see a reduction in those when we use medications. On average, about 60% of folks who get started on medication are abstinent after 1 year. And that's compared to about 80 to 90% of people who are not able to stay abstinent. So looking at somebody who does an abstinence only and they say, I'm not going to take medication, we have an 80 to 90% relapse rate. And then also somebody might just say, I just want to get off of this. I just want to get off and be better. I had a doctor friend say to me, what? This person hadn't used for a week. They were already through the detox. Why did they go back? Well, again, I go back to this is a circuitry change in the brain. The circuits didn't change. The circuits are still there. So detox is not considered treatment. They're just not having withdrawal symptoms anymore. So opioid agonist treatment in particular, this was a study from 2003. It was actually pretty profound. There were only 40 people in this study. 20 of them got buprenorphine, which is another, you may have heard Suboxone, that was one of the first brand names, but buprenorphine is the generic. 40 people got buprenorphine, and then, 20 got buprenorphine and 20 did not get any medication. They all had equal psychological interventions and opportunities. At 1 year, there were still 15 people, so 75% were still in treatment for the buprenorphine. There were none after about 2 months in the control group, and there were 4 people who died of an overdose in the control group. It was pretty profound. These types of studies have continued to, be in the literature, and it's the information is not arguable. The other findings we get is that we see, as I said, is hepatitis C and HIV is markedly reduced. So again, my picture for overview of other medications. I talk about the receptors as a key and a lock and a key, I should say. When we talk about a full agonist, it's like putting a key in the door, opening it, and the door will open as wide as you want it to go. That's an agonist. That's taking oxycodone. You could continue to take more and more and more. The door will swing wider and wider, and therefore somebody could conceivably have a risk for overdose. When we talk about partial agonists, it's one of those locks on the chain locks, like on a hotel. So the key works, but it's only going to open a certain amount. So that's sort of that partial, an example or a way to think of partial. It doesn't fit perfectly, but it still does open the door. So the first medication that we know that's FDA approved is methadone. Methadone's been around since the 1960s. It is a full opioid agonist. Some people take it for pain management too. But used in the setting of substance use disorders, it's very effective because it has a very, very long half-life. You take 1 dose a day, and it lasts the entire day. In fact, I would contend it probably would last for a couple of days to reduce the side effects of withdrawal and maintain a sense of well-being. It has to be dispensed at a specially licensed, federally regulated facility. So you might hear methadone clinics, they're now called opioid treatment programs, or OTPs. There is an overdose risk, though because of primarily more of the unique properties that are associated with methadone. And then in methadone also we need to evaluate for cardiac arrhythmia, so there's some risks associated with those. It's very hard to divert methadone because you have to take your dose when you go and see when you go to the facility. People have to go every day. I mean, it's a big deal when you make that commitment. But people do very, very well on methadone. It's an evidence-based treatment. The next medication is a partial, so it opens the door a little bit, but doesn't go all the way, and that's what I mean by a ceiling effect. The risk of somebody overdosing on buprenorphine is very, very low. When we talk about overdose with buprenorphine, typically it's because it's been being mixed with another medication that could sedate somebody. Xanax or benzodiazepines or alcohol. Those are my stopgaps and tell patients I can't tolerate somebody using alcohol or benzodiazepines while they're on buprenorphine for the risk of overdose. DEAX waiver refers to physicians need special training in being able to prescribe this medication. And so it's somewhat of a barrier, but I also think it is something that we really, really need to emphasize, so we're doing this right. I've been asked, well, you didn't have to take a special test to, prescribe oxycodone. And I say, and shouldn't we have? I mean, things might have been different. The DEAX waiver was only for physicians up till this year. And then the HHS Secretary Burwell, she wrote another bill. So now nurse practitioners and PAs they will be able to prescribe as of February 2017. They're going to be required to have 24 hours of training, and I don't know when this, I can't answer why it's so different for physicians. This can be prescribed out of the office. This is one of the main medications that I prescribe to patients. And there are limits. In their first year, physicians can prescribe for 30 patients. In the second year, they can prescribe up to 100 patients. And if they're specially trained or board certified, they can prescribe up to 275 for 275 patients. So there's a limitation. These are just some of the brand names and how it comes. So the advantages, certainly it allows for a functional life, if somebody has an opioid use disorder. It is amazing to have a patient come into the office and be in withdrawal, which they have to be in withdrawal before they take this medication, for reasons I won't go into just yet or today. But it's amazing. They'll bring the prescription with them. They'll take it in the office. They will look like they're going to vomit. I've got a vomit basin, emesis basin for them. I'll sit with them for 5 minutes, decide they're going to be doing okay, walk out, come back in 10 minutes, and they go, I'm good. And it's really phenomenal. And not only that, they come back and they go, I can't believe how good I feel. I didn't have cravings, and it's really one of the most satisfying things to see people say, oh my God, I didn't know this was possible. We know it reduces using days, it prolongs the time to relapse, and as I keep emphasizing, reduces infectious disease. Pitfalls, certainly it can be diverted. People can go and sell it. It's got a street value, no question. I'm also told by folks behind prison walls that it's one of the most diverted and divertible medication in prison. Sometimes there's a misunderstanding of purpose, like are you prescribing this to just detox me, or is this going to make me feel high? I'm not feeling high. That's really not the purpose. And then impacts on clinical and staff. It does require close monitoring, and on occasion I've gotten visited by a DEA officer and they don't smile. So it's because it's such high risk for diversion and misuse. I have to kind of prove to them that yes, I'm keeping lists of all my patients. I'm going through the guidelines and using utmost care in prescribing it. And then the last one is that's FDA approved is called naltrexone. This is like sticking gum in the lock. So suddenly it's blocking things. It's not going to open any doors. It's going to block it. Nothing can get in there. So if somebody is on naltrexone and they go and they use oxycodone, or if they use heroin or fentanyl, they won't have any effect. It's kind of a waste. So, but we know that it reduces cravings. It does not create a dependence for patients, so they won't have any withdrawal effects if they were to stop it. It comes in, as we would say, a convenient injection every 28 days. You would think a lot more people would go for this. Like, wouldn't that be great? You don't have to go see your doctor every 28 days. It's just not that easy. This medication requires that somebody is off opioids for 14 days. It's really, really hard to make that deal and say, you're going to be okay. Anne and I have had one patient who said, I don't care. I've seen 6 of my friends die in the past 6 months. I don't want to die. And, white knuckling it. And he was on naltrexone for a period of time, and I don't want to talk anymore about him. It was a bad outcome for a variety of reasons. But he was doing very well on Vivitrol. He was a patient, actually, who was telling 2 friends about it and telling 2 more friends about it. So we know that it is a good med. It's hard to get folks to get on it. And this is, naltrexone is a form of naloxone. Perhaps you've heard of Narcan, the whole, the medication that saves somebody's life if they are having this respiratory emergency. Narcan goes in, just like naltrexone. It's the gum in the lock, but not only that, it will kick the key out. So if there's a key in there, whether it's heroin or fentanyl or whatever, it'll go in and kick the key out, therefore it miraculously saves somebody's life. So that's essentially how Narcan or naloxone works. It's an antagonist. So our overall goal really is for people to be in recovery, and that's, when patients come to see me, I say I'm not treating your chemical dependency. In other words, I'm not just giving you a drug, a medication, so that your life can go on as usual, because their as usual is probably not that great. When people get into recovery, they find their health-related issues improve. Family reunions happen. People, move out of apartments that they've had to live with somebody else because they couldn't afford their other their own place to live. That we know that there's reduced criminal activity, there's reduced recidivism, there's job retention. I like to tell the story of our patient, one of our patients who came in with a wedding ring on. He said, I've been married for 4 years and wasn't able to afford a wedding ring. And my wife and I went and got wedding rings this weekend. He also bought himself a new pair of sneakers, which I don't think he had bought for many, many years. And the other thing I mentioned is citizenship. We've seen these recovery communities rising up because it's this sense of rebirth of life. I've got my life back, and I don't want anyone to feel the way I was feeling in the past. And that's really the strength behind the recovery communities, folks who have had lived experience and peer support. And I love using the word joy because I think we all want that. We want to feel well in our lives, and we want to bring forward and go forward and bring joy to our lives and to others' lives. And that's what I hear from patients who are really doing great. And they come into our practice, and it's just amazing. It's just an amazing experience, and it's one of those things that I try to express to my primary care colleagues and say, oh, you just get one patient, and it's just one of the most satisfying things to see somebody come from practically falling over a cliff, literally, and their lives are back. That concludes my presentation.